We are already late by hours, so being a part of the host, I think it's quoting Shakespeare that since brevity is the soul of wit, I should be brief. I think I thank Dr. Madhvi because you have already made my job easier by presenting most of the things. I will only talk to as a clinician's dilemma. Every time, like my interest in MPN started out 3 decades back when I used to have an special interest in patients with Budd-Chiari syndrome and extrahepatic portal venous obstruction. And that time, the gastroenterologist used to say either from AIMS and SGPGI that is because of a web formation, it's because of an infection that the portal vein is blocked and you get a Budd-Chiari syndrome. And my colleague, Dr. Sanjana Dayal, was doing PhD in this field, and now she is a professor at University of Iowa. We were looking at the basic pathogenesis in these patients, and at that time we only had a red cell mass assay to be done to find out whether there was a myeloproliferative disorder or not. And she's developed the long-term colonic cultures. Now we understand that these mutations produce a self-renewal process of this hematopoietic stem cells, and they are the hallmark of polycythemia vera. So we did publish initial papers, and that they got published that actually what you were seeing in India as a Budd-Chiari syndrome and patients with hepatic extrahepatic portal vein obstruction, that is the splenic vein thrombosis, more than 30 to 40% of these patients were actually having an underlying polycythemia vera, which you did not pick up. Now, in the past decade, our job became easier because in such patients, we started ordering JAK2 mutation. And once the patient became positive for the JAK2 mutation, you found that the patient had an elevated hemoglobin or a thrombocytosis, you could classify. But as a clinician, again, it struck to me that, okay, we have the 3 driver mutation, the JAK2, the CALRA, the MPL. Why does one patient actually go ahead to develop a polycythemia vera, the another an ET, and another patient develops a myelofibrosis? And as the research is going on, more and more information is coming. And even if there is a patient whom you find that there is a JAK2 mutation present and it presents as a polycythemia vera, you find that one subset of patients behave in a different fashion and another patient presents in a different fashion. So briefly in this few slides, I'll try to give my viewpoint and try to find out some of the solutions to my dilemma, which will probably also be there in the minds of the clinician. And also I keep troubling my pathologist to find an answer for me. Dr. Namrata would have been a patient with me. She would have experienced the number of times I tried pushing her to find a solution to my answers. So, and I keep skipping the slides because they've all been covered by. We'll not be talking about CML because that's an entity by itself. So we are talking of the PRV, the ET, and the primary myelofibrosis. So this is how the diagnosis again we have covered up. What I would try to emphasize upon is that BCR-ABL was there, a well-known documented Philadelphia for the CML. We do not have a marker cytogenetic abnormality in a PV or an ET, but in primary myelofibrosis, around 30% of these patients would have cytogenetic abnormality being present at the diagnosis. So this is one of the hallmarks. So sometimes do not, wherever you have an element of doubt, whether to classify the patient as an ET, MF, and you're not able to get so-called, there's the role of cytogenetic abnormal detection study is also important. Now, already it has been, everybody is aware of the JAK2 mutations, so I'll skip this slide. What I would like to say is that based on the JAK2 mutation, the classification has of the recent classifications of WHO, which Dr. Madhvi has already elucidated. But just highlighting a point is that the presence of these 3 driver mutations have now classified the primary myeloproliferative disorders. So just again to recapitulate from the previous speaker, in polycythemia, 100% are JAK2 positive, either exon 14 or 12. 14 is more common than 12. ET in around 60 to 65, the JAK2. 20 to 25% will be CALRA, and PMF 60 to 65 is the JAK2. So this is what I was trying to stress upon, that we are seeing JAK2 across the 3 spectrum of the disease. Why does one land up having a PV, the other with a ET, and other with a primary myelofibrosis. So this is again just looking at the slide and recapitulating it as to there for a briefly for my clinicians if they are there in the audience, just to remember as a home taking notes. Now, the next step that we were wondering is that, okay, this myeloproliferative disorder is actually of the myeloid series. Does it affect the other cell lineages? It's just the same correlate like we talk of PNH. We say that it is the red cell, the erythroid precursors, but when we went on to study, we found that the neutrophils are affected, the monocytes, and even the platelets have a GPI anchor protein being deficient. So again, the same situation arises here that if you talk of JAK2 mutation and talk of polycythemia, we are talking of only the cells of the erythroid series, or we are talking of the platelet series. But if you look at it, even the granulocytes and the platelets would actually be carrying these JAK2 mutations. And probably the JAK2 mutations are more present in the platelets when you compare with the myeloid cells. So this is one of the near learning experience for me, is that the JAK2X is actually present across all the three lineages of the cell. So this probably could be actually explaining the clinical manifestations. The second point important was that we were come down to the calreticulin mutation. This again has been incorporated, so I just skip on the slides quick enough. Probably a fast reading. Now, this emphasis is before I go on to the slides, I just try to emphasize on this slide is because is that for the calreticulin, there are two types of mutations, the type 1 and the type 2. The type 1 is around 52 base pair deletions and the type 1, and the type 2 is a 5 pair insertions. And it has been found in the last line, if you read that the platelet count in the clip for a clinician is important, is usually higher in those with type 2 mutations than those with the type 1 mutation. Just keep it in your back of mind when I just do a comparative slides and show you the difference as to why this, knowing the type 1 or the type 2 of calreticulin mutation is important. You will understand what is the difference in the clinical phenotype presentation of this, the MPNs. And coming down to once, actually, this is a sequence of development. If you see the historically, the JAK2 was there. Once we found that after the JAK2 we studied and we found the calreticulin. And when the cases were there, we found these two were not there. The third entity which came to know and the driver mutation was the MPN. So this MPN mutations is in a prevalence is far lesser. It's around 5% in primary myelofibrosis and just around 1% of the ETs. So the frequency is usually very less. So the most important is the JAK2 and the calreticulin. Now, if we see what are the, this is just a recapitulating on the prevalence of the incidence. Now, if you look at overall patients of primary myelofibrosis also, 58% would have a JAK2 and MPL would be around only on 9%. So if you look at MPL mutation across, it's more frequent in primary myelofibrosis, but the incidence doesn't exceed more than 10% as I. So from a clinician viewpoint that we know that the three driver mutations, what exactly, how does it affect determine the clinical phenotype? Does it have an impact on the leukemic transformation? Because when you are as a clinician following up these patients over a period of 7 years, 8 years, or 10 years, you'll find these patients evolving, polycythemia going into myelofibrosis, myelofibrosis patients going on to become an MDS or an acute leukemia. Does these three driver mutations have an important? And what is the level of involvement of stem cells in this disorder? So I'll just briefly focus on these two, determining the phenotype and the leukemic transformation of these three driver mutations on the MPN, in the MPNs. So this is a slide which I would like to focus, that we only do the qualitative JAK2 mutations. We say JAK2 positive, JAK2 negative. It stuck to me in a time that in a CML, we always talk of the burden, the BCR able, we talk of quantification, we talk of 92% to start with, we give a chemotherapy, and as it reduces, we try to define the clinical outcome and the response. So 10% at 3 months, 1% at 6 months, and 0.1% at 12 months. That's how the NCLN divides. Why not have extended this hypothesis or this observation to, say, a polycythemia vera patient or a patient with an ET? That what is the impact and why not quantitative? So my thought is not new. People have thought before me and there are papers on it, and that what they have said is that if you do a quantitative analysis of the JAK2 mutations, if you find that the percentage in patients with polycythemia vera and fibrotic pre-myelofibrosis is more than 50%. And if the in patients with ET and pre-fibrotic MPF, it's less than 5%. So probably that's the difference. So the allele burden actually also defines how the disease progresses. So you have a higher allele burden, the probability of those patients manifesting as polycythemia vera is more and ET is less. So I think the next stage in the development of hematopathology in the lab side would be also to be actually quantifying the JAK2 mutations. It's a little bit tough job, especially and the other in these patients. And the second is you may also say that in a ET patient, the burden will be low because most of these JAK2 mutations are heterozygous. So I was just going through the review of the literature. Uh, there's again a conflict of idea between whether the manifestations and the allele burdens actually correlate with the homozygosity and the heterozygosity or not. So it's a little bit beyond the scope of the time frame that has been given to me. Now we have around 95% having the exon 14 mutations. What is there will be the rest of the subsets that is around 3 to 5% will have the exon 12 mutations. So is there a clinical phenotype difference between a JAK2 exon 14 mutation and an exon 12 mutations? In our own clinical practice, every day we see our residents come and say, okay, so the patient has got a hemoglobin of 18, 21, is going on a regular phlebotomy, and the JAK2 exon 14 has come negative. So we said, go ahead and do an exon 12. So, but it comes again from a back, it comes as a negative, and I'll tell you one of the reasons probably which I hypothesize is why. And when would you suspect that this patient has got a exon 12 mutation is highlighted? It's at younger age, usually less than 50 years. And 40% and those patients who below 50 years of age, 40% would actually be having an exon 12 mutation. So in your clinical algorithm, keep it in mind. We have started observing many patients at 40, 45 years coming with a hemoglobin of 21. And we find that when we do the exon 14 mutation, it's negative. We do the exon 12 mutation, it still comes negative. The reason that which I looked at is that exon 12 mutations, the burden is lower. It's not as high as exon 14 mutations. So it can be 1%, 2%. So in a standard technique, my colleagues would be better. A Sanger sequencing might miss them. So what they say is that doing an allele specific RT-PCR would be a more appropriate. So I think I should be going back to my clinical practice and call these patients up and look at them and say, okay, what is actually the JAK2 exon 12 mutations? What is the allele burden, and see and define those patients. People in the audience may correct me who are really from the pure pathology background. This is the clinician's dilemma. Is the clinicians who drive the pathologist. So you all in a science, you always need to be corrected because what is your thought process may not be always right. But this is an area wherein I think I need to really look into it. And the other characteristic feature is which I always taught my clinicians is suspect polycythemia only when you also have an elevated platelet count and a WBC count. That was the standard rule of the thumb. But when I looked at the exon 12 mutation, I realized that it is only specific to the erythroid. These patients will come only with elevated hemoglobin 18, 20, 21, requiring a phlebotomy. The WBC is within the normal range. The platelet is within the normal range. Why it happens, how it happens, we do not know, because both exon 12 and exon 14 is actually acting at the same point on the MPO receptors level. But why does it only influence the erythroid series? We do not know. So this is very interesting, a new area which has opened up. We need to better understand the pathophysiology and implicate of this exon 12 mutation. So now we come down to the second part of the question, which I said that the JAK2 mutation is the same in both in ET patients and in the polycythemia vera patients. Why is it one? What is the difference between the two? You may actually in a clinician be or at the side be have a problem. So just I made a table in a form and see that what exactly does the allele burden do in polycythemia. So please don't correlate both polycythemia and essential thrombocythemia versus is just a block separate that we're talking of polycythemia with a high allele burden more than 50% or less than 50%. We're talking of ET with a high burden and a low burden. It's not comparison between the two entity. So clinically, those polycythemia vera which have a higher allele burden have a more risk of thrombosis. So it correlates with the risk of thrombosis. Higher the allele burden, the higher risk of thrombosis. You will invariably get those patients have a clinically splenomegaly. If the burden is low, the chances of having a specific high massive splenomegaly is lower. And in the lab side, you will see a higher hemoglobin level, a higher WBC count, but a lower platelet level in those patients with a higher allele burden. So this is for my clinicians to take home as to when to you suspect that these patients could actually be having allele. So there it signifies that just doing a quantitative is not important, qualitative, but quantitative has to be now come into your clinical practice, like you do for PCR. Now, if you look into the ET, the same is that if the allele burden is there, the risk of thrombosis is again higher. So you can predict those patients are subsets of patients who will have a thrombosis. And similarly, the WBC count correlates inversely and the platelet counts are low. Now, both of those patients who have a higher allele burden will have a higher risk to progress to PMF or now we'll be going a little bit fast because the time shows me that I'm a bit slow in presenting, but just as to emphasize the point. Now, if you take the ET patients when compared to the JAK2, ET with JAK2 and ET with calreticulin, those with MPL have a characteristic features that they have a higher platelet count, there is an isolated megakaryocytic proliferation, and the serum EPO levels are higher. This is when you compare a patient with an MPL mutation with a JAK2. So just remember that if you have a very high platelet count and going into say 14, 15 lakhs, and if you have only a without it affecting the WBC or the hemoglobin on the higher side, then probably you may be dealing with the EPL mutations to be under. But however, it has no prognostic impact that it doesn't change its progression into PF. Now, this is again a combination which I said of type 1 and type 2. So what is the difference between the clinical presentation? So probably you could look at it if it is an ET, a type 1 mutation is more common in MF, whereas a type 2 will be within ET. This is highlighted. And overall prognostication shows that those with type 2 have a better prognosis when compared to those with the type 1 mutations. So now we just then find this slide is an interesting that if in case of a PMF, if you see these 3 mutations, does it have an impact? Then yes, those PMF patients who have a calreticulin mutations have a better prognosis, a longer survival when those compared with a JAK2 or those who are with triple negative, as my previous speaker had said. So, but there was few unquestioned answers still unquestioned that, okay, this is the disease, this you have already done the disease burden. We had, so we stretched our DAG because you had an NGS2. So you said, let us look at the somatic mutations, and the host of somatic mutations have been discussed. I think just can you help me with just a last slide, which I close my talk. So we'll not discuss anything, but what I'll just try to summarize in this slide is the 2 mutations that we're talking of, the TET2 mutations and the DNMT3A. So what I found interesting was on the TET2 mutation, what it says is that if you have a TET2 mutation there preceding a JAK2 mutation coming, the probability of developing an ET is higher. This is just a scientific hypothesis that has been put forward. In contrast, if you have a JAK2 mutation being present, followed by a TET2 mutation, then you have a probability of a polycythemia vera. And looking at the other somatic mutations, EZH2 and ASXL1 and SRF splicing factor, they have an associated poor prognosis. So if you look at the PMF patients who have transformed or gone into MDS, then in addition to the one of the 3 driver mutations, if they have additional 2 or 3 somatic mutations, then the progression is faster. So, but as a clinician, once the patient has progressed, you retrospect, you do the test, you will get a positive. But the question is, doing at the start of it is the same question that I keep asking me, that today the patient comes and you do a NGS and look at the somatic mutation and the patient has a TET2 mutation. Is it going to impact the prognosis and outcome of the disease? The answer is still not there with me. Many a times my colleagues make a problem with me. They diagnose an MDS, they do an NGS, they get a TET2 mutation, and they start saying this patient is going to have a prognosis and treat. I, as a clinician, will still say treat the patient and not treat the molecular test that has come to you. This is my opinion. So you have a new tool, you start doing a test, be patient. Only when you're patient, the science will unravel itself. It will take you time to actually address how exactly the mechanisms do it. So it was a big difficult topic. I have tried to digest it, simplify it, and present as I look at the problem myself. I hope you enjoyed listening to me and have patience with me. Thank you very much. And I think a lovely dinner, lunch has been laid out for you all, so you can enjoy our hospitality. Thank you once again for a patient hearing and being sitting here till beyond 2 o'clock. Thank you.